Okay, everybody, thank you very much. Welcome back. You always worry as a chair that you've lost somebody when you've allowed them to go to the loo, but I can see we've got everybody back, so thank you very much for coming back. We want to move on now to the next item on the agenda, which is, again, a very important part of our work, which is improving care through population health management. And may I welcome Sam Green and Sai Ganesharatnam to lead us through it, and then we'll have some questions. So off you go.
Thank you, Chair. I'm Sam Green. I'm the Head of Population Health Management in South West London, and I'm going to be talking a little bit about population health management in South West London, where we're at, what our plans are, inform you about the roadmap and the implementation plan, and obviously outline some risks and interdependencies. One of the things I thought I'd start with is, what is population health management? Because when we do lots of engagement, there seem to be lots of definitions, lots of ideas about population health management. So we decided to create a common understanding and a definition, and it's about using the data that's available to identify cohorts of people, of the population, and use that data to really design interventions that will tackle the inequalities and health issues of the patients, and really add the most value, and that we can measure the impact from that data. So why do we do population health management? It's really to understand the needs of the whole population and understand them and what matters to them. It gives us an opportunity to move from prevention to proactive care and holistic care, better joint working, and it gives us an opportunity to work together in a targeted way with those populations as well. Population health is lots of people involved in it already in South West London. There's areas of good practice and lots of good people, but it's not evenly distributed. We're not sharing good practice, and people aren't using the data and the support that's available at the moment. I'm going to hand over to Sai, because Sai was part of a population health management pilot in South West London, in East Merton, and he'll explain a little bit more about population health management in action, how it works.
Thanks, Sam. Hi, everyone. I'm Sai Ganesharatnam, and I am a PCN Clinical Director for East Merton Primary Care Network. It's worth just telling a little bit about East Merton Primary Care Network. So we're based in the east of Merton. We've got 5 practices, a population of approximately 48,000 people. We're in the most deprived part of East Merton, so we're at the 5th quintile of deprivation, a significant BME population. About 60% of our patients are BME, higher than average prevalence of severe mental illness, diabetes, cardiovascular disease. So it's a really rewarding but also challenging environment to work in. And so when we had the opportunity to be part of the Optum Population Health Management Programme, we seized it. We thought it would be a fantastic way of working with partners and with the people of East Merton to try and identify actionable insights into population health, and that is really what the Optimum programme provided us with. So we looked at the data, but we also shared our lived experience of what it was like to work in East Merton amongst professionals, and as part of that we also engaged with patients as well. And what we identified was a very specific group that we wanted to work with and help, and that was those with severe mental illness. So severe mental illness is those with, for example, psychosis, schizophrenia, bipolar disorder, severe depression. And we wanted to look at those who had severe mental illness but also had drug and alcohol dependency. So across East Merton, there are approximately 60 people like that. And what we noticed when we looked at the data was that they were disproportionately accessing accident and emergency departments. They were disproportionately accessing primary care services. They also weren't attending appointments sometimes as well, and they weren't attending for their annual physical health check in general practice. So only 10% of them had actually attended their annual physical health check, compared to over 70% with regards to the rest of that particular population. So we thought, what can we do to help that particular group? So as a network, we worked with partners. So we worked with South West London St George's, we spoke to secondary care. We also ran a series of workshops with those with severe mental illness and drug and alcohol dependency, and we actually asked them, how can we help you? And actually that was really insightful, and what they told us was that actually their lives are so chaotic, so difficult, that actually that was not the first thing on the list of things to do. There were other things that they needed help with. They also talked about sometimes being afraid to leave the home because of COVID, and they just found things far too complicated. Some of them didn't even know that they actually had to attend the GP for an annual physical health check. What we also found was actually it was tremendously helpful to access the wider workforce within our practices. So now that we're primary care networks, we also have care coordinators and health and wellbeing coaches. And actually, when contacting and speaking to them, actually those particular members of our team were tremendously useful, because as well as them actually starting to help them make sense of their lives, they were also coaching them to better understand how they can start to manage their own health and well-being, because it's not just about what we can offer in terms of traditional health and care services, it's how we can help people to manage their own health and well-being better as well. So through that process, we then started to think about how can we do things differently? How can we start to take action and try and prevent them necessarily having to go to ED, allow them to start to manage their health and well-being better. And so we're working towards, number one, seeing if we can start to deliver services in a very different way. So we're working with the local authority around Health on the High Street initiative. Merton is a borough that is really passionate about getting people active, and also has mental health really high on its agenda, because our place leader is the Chief Executive of South West and St George's. So we are looking to do something in this area anyway. We hope to try and work towards more of a health and well-being hub type approach to something like this, where when people do go and have their physical health checks, they also can speak to the link worker, they can go and see the dentist, they can speak to citizens' advice, they can start to make sense of their lives. And that's really what we're aiming to do. In terms of how we're looking to evaluate that, we're going to use wellbeing scores like ONS4. We're going to measure how often they attend their physical health checks. We're going to look at other sort of linked data sets, such as non-elective activity, for example. In the short term, we're hoping that we'll see an improvement in uptake of the physical health, the annual health check with the GP, and that has happened. So we've gone from 10% to 35%, which is a tremendous improvement. Obviously, that's still not good enough. We want to, we're aiming for 100%. We're seeing better medications adherence in those people that have attended for those health checks. So they're some of the positives. But I think the longer term, it's really about how we can work towards making better use of the resources that are available to us. So how do we access the wider team and work better with partners? Because there are some things that we can just streamline and do better. So what the mental health team does and what the primary care team does, there is some overlap there. So how can we work together and do things better in a more efficient way? And the ambition, is to really work towards a model of care where which the people are taking ownership of their own health and well-being, and we are just there as add-ons, bolt-ons to what they do, with their lives. So that's the aspiration. But it's always challenging. You're trying to build for tomorrow, but then you're dealing with today and the pressures of today.
Thank you very much. Do you want to add anything to that, Sam, before I throw it open?
Yes, I do have some additional comments. Obviously, Sai's really brought that to life as a population health management approach. We've developed the implementation plan and the roadmap with lots of engagement. It really outlines the things we can do to support and help the system. We are at the early stages of the PHM journey in South West London, and we've identified some key interdependencies as well, particularly around the system intelligence function, and the PHM team will be linking in with the people that are involved in that. We have identified some risks in terms of how we can develop some of the PHM methodology and approach in the system. Data and analytics was one area. There's a high vacancy rate in the analytics team. While we've carved out some PHM support from analysts for PHM, we will be linking in with the Chief Operating Officer as the PHM team to actually work alongside them with that to understand that, and also the digital team as well. There's a PHM platform. We have currently Health Insights, which is available. We're trying to maximise usage of that and self-service of that as well. There is a national product due, so we need to work again together with the people that are going to working on that product and look at how we can do that assessment for the future, with PHM in mind, or population health management. We also need to carve out some time as a system for OD to focus on a planned and proactive approach for population health management. The PHM team can support with that because we have lots of resources, we have a community of practice that we're going to be developed, all those things that we've outlined in the roadmap and the recommendations in the implementation plan. And the PHM team will be focused on the pilots that we're proposing that are happening, connection and coordination of all of the resources and all of the support that we have to move forward together. And there's some clarity needed on the senior clinical leadership required as well. So in summary, we've taken you through why PHM is important, what the recommendations are that we feel are needed, and how we can increase capacity and capability to deliver PHM moving forward, and obviously offer an opportunity to have further discussion with the board around that. Thank you, Chair.
Thank you very much, Sam. And Sai, questions and comments on what you've heard and what you've read in the paper? Jonathan?
Thank you very much. Just to introduce myself to everyone, I'm Jonathan Bates. I'm the Chief Operating Officer of the ICB. I just wanted to start by saying how pivotal I think this is to the 4 priorities you highlighted at the beginning, Millie, around patient outcomes, health inequalities, tackling social determinants of health, and actually productivity. This programme of work cuts across all 4 of those, so it's really good to have this at the first board meeting here. And what I wanted just to draw out was the system intelligence piece and the breadth of that, which you've already alluded to, Sam, which of course population health management is a key part of. But to make the board aware there's more work that we need to do, not only in the PHM space, but also around business intelligence generally, analytics, information governance, and the work that we need to do to develop a system intelligence function, which we're beginning to think through, but might be something also for a future board meeting when we've progressed it a little further, Chair, to come back and reflect on again. But a really good piece of work, and I commend you both for it, and thank you, Sai, for bringing it to life. Really appreciate that.
Thank you very much, Jonathan. I've got Karen and then Jacqueline. Karen.
So thank you. So I was just going to ask a couple of questions, really. I suppose my overarching question is, what did it give you that you didn't have before? So this thing that we call population health management, what does it give you that you didn't have before? But also, how's that going to now change how you provide care to patients going forward?
And Jacqueline?
Thank you very much. Thank you, both of you. Absolutely pivotal to where we go with health, generally across the UK, but particularly for us in South West London, which is what we care passionately about. But my bit was about the fact that we've got 2 universities, and one of them, which is St George's, actually has a population health unit. And actually, how do we dovetail into that so we can keep ahead of the game? And I hope as well that at some point the board will think about bringing a research, development and innovation strategy here, because it's really important for South West London that we keep ahead of the game. Thank you.
And I have Annette and then Dagmar.
Thank you.
Mercy, I can't see you. Annette, Dagmar and then Mercy.
Thank you. And Sam, very nice to meet you. I'm Annette Pouts. I'm a GP in Kingston, and I'm here as the Kingston Place member. So I think this is an excellent paper, and particularly I think it's excellent in that it pulls out the issues really clearly, and I agree with the issues. I think this is an enormous opportunity, and I think the public health, the population health program that was run was an excellent program, and I was lucky enough to attend some of it. So it was that's been really good. This is a big opportunity, but I'm just going to reiterate what some other members have said, is that it is going to be reliant on the analytical skills and platform that we have. And I think we need to be really open-minded about that. We need to be mindful of what Jacqueline's just said, but also our public health colleagues have a lot of data. They already have established data analytics as well, and I think we really need to be open about what the best solution for South West London is going to be, that's going to see us into the future, because if we don't get that part of this right, we won't get population health management right, and population health management is critical to how we work moving forwards, but also it's critical to prevention. And if we don't tackle prevention, we won't ever change the capacity of the health system.
Thank you. And then Dagmar, Mercy and Karen.
Yeah, so that's quite helpful. Thank you for this segue, because I am the Director of Public Health, and obviously I've worked very closely with Sam and Sai on population health management. And so I absolutely welcome it, and I really want to urge the board to commit to that. The roadmap is just the start, and we now really have to work on absolutely embedding it as an approach. And that's not just with a little bit of burning the midnight oil. It does need some constant proper development of infrastructure, resource, so capacity, capability and culture. It's not a done job, it is a really welcome start. Generally, we're inundated in data, but we are short of intelligence. And if you then ask what are the killer questions, we can't answer them. And Karen, just to your question, what are some of the killer questions that public health, that population health management wants to answer? We're really strong in numbers. We're counting. 70% of our people are screened. Yeah? That's the type of stuff we look at board level. If I then go down and say, "Ooh, that means 1 in 3 isn't," and then I ask, who isn't? These are the important questions that population health management allows us to drill in, and it really links to what Gloria will come up a bit later in how do we target inequalities. So I'm just pleading with the board to also really enable place, because at place you really have the killer questions and you have the granularity of what Sai has so well documented. So we need South West London to enable us to push this forward. Thank you.
Very much. I've got Callie, and then, sorry, Mercy, and then Callie.
I think it's Mercy first, yeah.
Mercy sitting in the wrong place.
Yeah, thank you very much. I'm really interested in this kind of area, and thanks for the report. It's really interesting. Maybe going back to Sai, because it was really a very good example that you gave about kind of reaching people and things. So just picking up on that, how did you kind of link in, or are you linking in with the voluntary and community kind of support for those people, if it exists, of course, and if they have capacity to do that? So I'm interested in that. And also, what have you learned for maybe other areas that you could kind of spread that learning through? Because you targeted a very, very specific group, but I'm sure there's a lot of learning for other people as well.
Thank you, and then Kay.
Thanks, Millie. And like everybody else, I really welcome this paper. It's great to see it. I'm going to raise a slightly different point, which is just to ask a question about supra-PCN models of working. And the reason I'm doing that, 2 reasons really. I was lucky enough to go and see Montefiore, the system in the Bronx in New York, and that relied on scale, both in terms of the intelligence and the data network, and then in terms of managing pathways for people. And so there's just something about scale, as well as targeting, where there's level of variation or levels of social deprivation that you need to address. So just a question about not losing sight of the supra-PCN initiative as well as the PCN-based initiatives, just so we can get that gain. So it's partly in my experience in Montefiore, but also in cancer, of course, you're often needing to operate over a larger catchment. So just checking whether that's on the agenda or not yet, whether it's very PCN-based. That was really the question.
Thank you. And then have I got Vanessa and then Nicola?
Thank you. My name is Vanessa Ford. I'm here representing the Mental Health Provider Collaborative. I'm also the Chief Executive of South West London St George's Mental Health Trust and the convener of Merton Place. So that was nifty, wasn't it? So but first of all, I just wanted to say thank you to Sai and the team around the work that we've done around SMI health checks, because actually that level of collaboration is the thing that makes the biggest difference to the people that we serve, and it's good. We need to do more of it and make it easier. But my second point was really in relation to the point you raised, Callie, about our opportunity, because within the mental health we have the provider collaborative that stretches across both South West London but also South East London, and the opportunities that we have to learn around the population health management tool across both, and to do things at scale. For example, the work that we're doing on psychosis, it's just to make sure that that's played in, but really fully support this piece of work.
Thank you. And then Nicola, and then I'm going to bring it to a close. Nicola?
Thank you. Purpose is really, really important with this, I think, and that's why it's so impressive what you've done in East Merton, you know, on a relatively short, small scale, and yet, you know, touched lots of people's lives. And I think the purpose of all this is really important. The balance of the benefits of scale and the creating a culture in PCNs at a really local level with their integrated teams, a bit like Callie was saying, you know, trying to get that balance right there is the theme again with this. I think we're going to see that repeatedly. And I just want to say one thing, which was about respecting people's data. I think it's something that this board is going to need to demonstrate, that we respect people's data, being clear about what we want to achieve through using it, and transparent about how we use it. I think that's something that we ought to make sure that we do.
Thank you very much. So, you've been asked a number of questions and comments. If you could keep them brief, that would be helpful. So, but I think you understand that there's a lot of energy in this room about what you've said. So over to you, Sam and Sai.
Okay, that's great to hear the energy. That's fantastic. I'll leave Sai to answer the questions around what it gave you and the opportunities and what they've changed, and the voluntary community support link. In terms of St George's, yes, Professor Chris Owen is part of our PHM programme board, so he's very involved in the work we're doing. In terms of Montefiore, that's fantastic that you've actually been there and seen that and have that. We are looking for a pilot in the future that is at scale, so that's one of the proposals, and you know, a couple of through the transformation programmes and the clinical networks as well. So we'll be learning more by doing with some of those. So we will pick that up, but I may contact you to hear a bit more about Montefiore if that's okay, because that's fantastic. And yes, definitely about the link with mental health. We really need to link in there, and we do have both from SLAM and South West London and St George's at our PHM programme board as well. So that's fantastic. Thank you.
And Sai?
So just to pick up on the other question, so what has population health management given us as a PCN? Initially it was a methodology, wasn't it? But really what we want to do is have a way of working, that we want to live and breathe population health working with our partners, and I think that's what it's given us. It's given us a new lens for how we do this, and it's allowing us to work with partners because everyone's enthused about it. It's making us think very differently about how we deliver our services. So rather being sort of adopting the traditional sense of I need to offer more appointments or I need to call patients, it's actually about asking people, what do you want, how do we work with you, once we've identified a particular actionable insight that we want to do something about. So that's what population health has really given us and what this programme has given us. And we're very early in the journey. I'm still learning. I think as a partnership, we're all still learning. The question about research, just as it mentioned, from a primary care network perspective, within our specification, it does explicitly state that we should be building partnerships with research and academic institutions. And that's probably an example of something you might want to do at a super PCN level, but bringing all PCNs together to see how we do that. So I think that is an opportunity that we should look at. Picking up on how we can leverage other sort of super PCN opportunities and how that might help us with population health within our neighbourhoods as well. I think there are different options for how we do that. In Merton, we have a pan-PCN partnership, so called Merton Health, which is a provider organisation that used to be a GP federation, but we then decided we'd focus on PCN specifically, and we've used that to deliver a very successful COVID vaccination programme. We've partnered with the third sector around how we reach out to communities already, and we have a fantastic relationship with local authority public health as well in doing so. So there are different options for how PCNs can work at a super PCN level. The most often used option usually is through working with other partners and with GP federations. But that's something that we're doing in Merton at the moment.
Thank you. Thank you very much. Sarah.
Could I just quickly say something on research? I do think we need to take a more strategic approach to research in South West London. I've been talking to some of the chief execs and also others in the system, and actually Dr. John Byrne, who is our medical director, will take a leadership role for the system on that work. And we need to link into, there is the medical schools and the university, there's the Institute of Cancer Research, based on the Sutton Hospital site. There's the HIN across South West London and South East London. So there is more work, I think, for us to do on that in South West London, and I think we need to take a very strategic approach, and we'll get John to take that up.
That's excellent. So the board is asked to note and approve the roadmap and the implementation plan. And thank you very much. I hope you found that helpful. Thank you, everybody, for your contribution.
Thank you, Millie. And I just want to say, yes, it does nicely flow at the back of what we've just heard about population health management. And hopefully I'll be able to demonstrate how we've actually used population health management to start thinking about the areas of health inequalities and how we can start tackling that across South West London. So, and as you can see, one of the 4 purposes of the ICB that we've just launched today is to really tackle health inequalities, improve outcomes, experience and access to actually reduce those gaps. And that is exactly what I'm aiming that we will be able to do by the time we've sort of like finished some of the things I'll be telling you. Health inequalities is not a thing, and I'm going to start with that. It has to be part of every single thing that we do. And that's why, and I think one of the ways we have to start this is about changing mindsets, changing culture. And it's not just peculiar to South West London, and I think it's just across the whole piece. In that, even from the board point of view, it's about how do we do that inequality impact assessment. And we are really want to start working on that. Whenever you produce a paper, you do anything, it's about thinking, who are these going to impact that actually that things will affect. And it's really interesting to see that most of the time you see people will say there's no impact. So again, it's about how do we start sort of like changing culture and experience. Now, in South West London, there's been a lot of work that's been done on health inequalities, and I'll tell you, we are doing like collection of work that's been done, and it's massive, and rightly so. So it's been in the forefront of everybody for a long time. But as we move into the ICB, one of the things we are thinking about is that we will not be able to address everything at the same time. And it's about where do we start from. It's a massive agenda. So we had a call from the NHS, that time NHS Public Health England, and they brought an approach in called 20+5. And we felt actually that might be a good approach to start in South West London, something that is very definite, is something that is measurable. And we decided that we're going to adopt that approach. And if you look at your people that have the booklet in front of them on page 164, that actually showed you what called 20+5 means. And I'll tell you in South West London, we've added our own 1 bit. So we call it called 20+5+1. And I will explain that to you as we go ahead. And if you look at it on that page, it actually gives you the definition of what that does. So what they mean by, I will divide this into 3 parts. If you look at the core 20 elements, core 20 means that you look at your 20% of your most deprived population in your area. And then the plus is out of those 20%, which of those people actually have the most difficulty, or probably difficulty in terms of accessing service, or are suffering the most. And I will explain to you how we've used that in South West London. And nationally, they've also interrogated data in terms of looking at where are the 5 areas clinically that we should be focusing on. And they've actually sort of like given us 5 areas. One is maternity, and rightly so, and I'm very passionate about that. it has to start from in utero. And there's a lot of things that have been put into that in terms of how we can make things better for pregnant women, which will then have impacts in terms of later life if we don't look after those fetus properly in utero. And they are up to that mental illness. And it's about how do we start looking at making sure that people that have mental illness are actually having their yearly health check done. And we are looking at improving physical care for them as well. Up to that, chronic respiratory diseases that we are aware of. And COVID has showed us a lot of things, and including shining a lot of light into the health inequalities that exist in the population before. Early diagnosis of cancer is a big one, and they've given us a target that we need to meet by 2028. And finally, it's about looking at hypertension as one of the biggest illness that we have within the society. And later you see in the paper, we've added one, which is diabetes. And you can see in Southwest London, that's one of our wicked issues that we are still trying to resolve. If you then look at your page 165, that actually tells you how we've applied the approach in Southwest London. We have used population health management to actually address this. And you can see what Sam said. Population health management is about looking at improving the health of the whole population. But within that is where does the health inequality lies. And this is where we key in. And if you look at the picture I've put on page 165, it tells you that out of the population of Southwest London, which is about 1.7 million, about 340 of those lives in that 20% of most deprived population. Already that is about 20% of your population. And can you imagine if you actually improve the health of those 20%, invariably to improve the health of your population indirectly, and to affect all the things that we want to address within the population. And then if you then look at your plus, and I'll pay your attention to like the third line, which again, Southwest London is highly dominated by white population. That is the fact. And if you then look at your 340 people, the majority of those people that lives in that most deprived population, 20%, are white, which is rightly so. But where the beauty of population health management is about, how do you then feature out those people that are actually having that health inequalities. And that is about applying the principle of universal proportionalism. And which means that if you take 10 people out of those population, many of them are actually in that your core 20 plus 5. So if you look at what I've put down here, if you take 10 Asian community in Southwest London, 2 of them actually are in that your core 20 plus 5. If you then take 10 black population out of your Southwest London population, 4.5 out of that, about half of that, actually live in your most deprived population. And you can see how that is actually stuck out. And then if you look at the mixed race, you have 2 out of 10. And then if you then look at your white population, by applying that principle of universal proportionalism, it will just be about 1.5 of those white population. So clearly you can see here, from here, that our plus is clearly the black population, which actually are predominantly about 5 out of 10 of the people you pick. And then if you then look at where people live and where these inequalities are, in the next page, which is your page 166, shows you the map of where these people live. We said 50% of our core 20 plus 5, core 20 lives in Croydon, and I'm sure you're aware of that from the work we've done with immunization and COVID vaccination. But the beauty of this is the fact that we have the numbers. We know exactly where to target now. We know where these people are and how we can start addressing those health inequalities. What we've done as well is to then move into, in terms of long-term sick illness, how many of these people are really sick, and are they getting the right care that they needed to get? And we know that in Southwest London, we have about 14 people that are very, very sick within that core 20 plus 5. And you can see on that page, it shows you where they live across the borough. But what we are then doing is to then liaise with the local GP and everything else to make sure that they are getting the right care that they need to get. Again, this is just demonstrating how we've actually used data to drill down into where problems are. And now we're going to start tackling those problems. And I would say, I'm sure you'll be thinking, now you've gathered all this information, so what next? What are you going to be doing next? What we felt is that you cannot address health inequalities by just thinking that, okay, this is what these people need, let's go and address it. And health inequalities is just not about race, it's about looking at those protective characteristics. And that's why you can see the 5 area doesn't just cover race, it covers everything. What we've done is to then think the best people that will give us the answer are the people in the community, the people that live and breathe those experiences. So we've been working closely with our voluntary organization within this sector, and Simon is here that sits within us in terms of some of the board and the things that we want to do. And we did apply for a bid to start looking at how do we put intervention in, really working with those communities. And we are one of the 11 ICS in the UK that won the collector's bid. So what we've done is that we are recruiting community connectors, people that represent those communities, go into those communities and co-developing intervention with those communities. And that is really important, especially for people like me, because I speak my language fluently, and it's Yoruba. Give me the book to read and write, I can't read any word of my language. So sometimes we then feel that interpreting leaflets will solve the problem, or doing a poster in those languages will solve the problem, but it doesn't. So at least I can really regard myself as actually averagely educated, but I can't read write my language. Talk less of people that are not really educated in those languages. So again, really working with those communities, co-producing the intervention, we think is the best way forward. And I would say as a whole, what we are doing is to make sure that we are actually bringing every partner with us. And I'm sure people understand, people live and breathe COP20+5 all over the place now. And yesterday we are at George's, really looking at the group module. How do we then sort of look at how we bring that into secondary care and everything else? So it's really spreading wide, and I have to say, doing all this, we can't do it without the help of our, obviously, local authority, public health, and we are working closely with them in terms of how we do that. Like I said, a lot of work has been done in the past. We've got to a stage whereby, by the time the ICP is birthed, one of their core aims is to reduce health inequalities. And we are preparing that work for that, to actually make sure that we are focusing on the right things. And one of the things we're going to be doing is to really looking at the joint strategic needs assessment that has been done across the piece, working with public health. And myself Dagmar had a quick chat in terms of getting every lead on that have developed that report together in Southwest London, and actually linking that to COP20+5, and also looking at health and care partner plan that we have across the piece. So again, it's going to be that collaboration and joint working, but mainly working with those communities that are actually experiencing those experiences. Thank you.
Thank you very much, Gloria. You hear the passion and you hear the content of what we're trying to do. So that was an excellent introduction. You've read the papers. Have you got any questions for Gloria? I'm looking around. Vanessa, Dagmar, and then Sarah. Go for it, Vanessa.
Thanks, Gloria, and thanks for your work on getting us this far. I've got 2 questions. In the next steps for delivery, it refers to Core 20, not Core 20+5, but I'm taking it is Core 20+5 that the recommendations relate to. That's just like a slightly pernickety question, but just so we're clear. But my next one was, it's great that we've got this short-term bid monies, and I'm presuming that it's short-term bid monies, but how are we going to create something that's more sustainable for our local communities to really engage and co-produce on it? And it might not be a question that we can answer now, but I think it's one that we have to ask ourselves. Because unless we invest in our communities to build the infrastructure, we're just going to come up with the same health answers that we always have. So.
Thank you. And then Dagmar, and then you.
Yeah, so thank you very much, Gloria. Lots of work has come in. I've got 2 sort of comments, one responding to Gloria. It is really important to link up the data with the existing local data. So there are statutory requirements for each of the places to have a joint strategic needs assessment. And it is absolutely fundamentally important to triangulate the data. Because South West London level, it's an ecological analysis, so you put things together. You have to be a little bit careful to jump immediately to conclusions, and that's what local brings you, that you check for face validity. So there are processes now, and we've just had a chat, that we really have to anchor it locally so that we can all sing from the same hymn sheet. The other really important bit is about stigma. If you think about, now we found another label, you are somebody who lives in the 20% deprived areas. People don't like that. It's like loser on the forehead. Areas don't like it. You know, a whole area is now told, you are the 20% more deprived, and, you know, the property prices go down, the schools feel a bit iffy. You know, people don't want to go there. We have to be really careful that we are not inadvertently stigmatizing. So a rethink of the frame is really important. It is not to take away that it is one other important tool for us to better understand what we want to do, but a little bit of caution and more collaboration is required. Thank you.
Yeah, very important point. Thank you, Dagmar.
Thanks very much. I'm Ian Dodds. I'm the Director of Children's Services for Richmond Council and the Richmond Place representative. I was really pleased with this report, and in particular the focus on preventative programmes to engage those at greatest risk of poorer health outcomes. It's not going to surprise you, Gloria, to know that I'm going to ask you about children and young people and what focus there will be on them, because if we are truly going to invest in prevention, we need to do that at the earliest possible opportunity with children and young people. Not least because we know that we can identify in childhood indicators of later long-term conditions, including serious mental health illness, but also because children are often a really good way of engaging with adults if we take a whole family approach as well.
Thank you. Gloria, number of questions and comments. Oh, Nicola, did anybody else have a hand up? You, Nicola, go.
Yeah, thank you. I'm just thinking about how we ensure that throughout our system, throughout all the health and care workers, that people share our enthusiasm for these approaches. I think that's for us as leaders in our own organisations to think and consider, because, you know, we've talked about a population health management approach and now a quality improvement approach, and they're also performing to lots of different indicators out there. Every organisation has got its own list of to-dos and tasks and things that we have to focus on. And I think it's about creating clarity for people at the front line who already want to do this, but how do we enable them to, you know, share our approach, our enthusiasm, your enthusiasm for this, Gloria. You know, this is not easy. It's a bit of a kind of cultural revolution, isn't it, really? And I think it's just kind of pause for thought about how we create some simplicity for people out of all this complexity.
Gloria, there are a number of questions. I'm going to ask you to be very brief, if you wouldn't mind, and comment, because what you've generated is a lot of interest, and nobody's expecting you to answer all of those questions today, but give us a flavour of what you've heard and what your response is.
I just wanted to say thank you to everybody, and I'm going to start with in terms of resources, sustainability, and how do we co-produce with the community. And I'll say that is the core, and that's our focus. And I know that if we want to sustain this work, we will need some resources put into it. And I know that that's one of the focal of our executive and the board. And I know Sarah and Millie have fought greatly to make sure that we actually allocate resources to health inequalities. It might not be a lot of money, at least it's a starting point. And I also want to probably talk about stigmatization of people in Core 20 plus, Core 20. And I agree with you, definitely agree with that. But I think until everybody will start calling it out and then keep that focus on that group of people, then things will not change. So it's mainly the Core 20 and this approach, like we said, the other approaches, is just to mainly get people to understand it. Like what Nicola have said, people on the ground floor, granular, understand that there's something that they can use to actually tackle that. But it's not the only thing, and definitely trying to avoid that stigma. And I get it in terms of joint working, and we'll be doing that closely. Finally, I want to touch on children and young people. And I'll tell you now, when Core 20 plus 5 came out, and I looked at the 5 area, and I said, where are the children here? So we are one of the people working with Bola, that is the national lead for this, to actually develop something very similar for children and young people. And we've set up a children and young people board in Southwest London, and that's one of our priorities as we move forward. Thank you.
Thank you very much indeed. And again, thank you, Gloria. We note your report. I just want to make a couple of personal comments in reflection for what I've heard. I think it's really important that we hear the comments about engagement. And it isn't just helping, it's actually integral engagement. And I think, that's what we have to do as something we do as a normal course of events, and I know you absolutely understand that. The other comment that really struck me was the use of data. We have to be deeply analytical, but also sensitive about how we narrate what we see. We have to respect the people's sort of hearing of that data, which is a stigma point I think that Dagmar's made, and it could be a very slippery slope, and I think we need to be very careful about that. I know you will be. But also time and time again, the point is coming up on scale versus local. And it isn't scale versus local, it's actually scale and local. Scale and local. So let's not force ourselves into a false dichotomy, is that you can do one and not the other. Because unless we do things at scale, we're not going to achieve the outcomes at scale. But unless we aim it to the needs of the local community, we're not going to satisfy significant numbers of people. And the sustainability question is very important because we are going to have to make some difficult decisions when we get to it. It will be how do we use our money, because there won't be other sorts of funding necessarily coming our way. And it's a very good thing that today we're already starting to see where the priorities might be, and we will have to be faced with some difficult decisions of money as we move forward. Lastly, I'm very pleased that somebody made the point about the front end and what people feel. To me, it's really about inclusion. I don't think it's just about diversity. I think diversity is diversity. But if we don't create an inclusive environment, then diversity doesn't play. So really we need to include our people who deliver this message. We need to include the patients. We need to include the community. So that's another tenet, I think, that we need to keep developing in South West London. I know it's unusual for the chairman to speak a lot, but I feel so passionately about this program that I really felt that I wanted to bring some of the things that I heard to life. So thank you very much, Gloria. All right. May I move us on to the next part of the agenda, which is about updates and reports. And I think we start with the performance report. Is it you going to speak, Jonathan?
Yes, absolutely, Millie. Thank you. Thank you very much. So this is a standing report the board will receive. It's worth, I think, highlighting. It covers acute mental health, community primary care, and other key areas that are relevant to borough and place. But it is a high-level summary report. It covers 36 metrics. There are hundreds of metrics that we could look at, but it looks at 36 at this point in time. And the paper also highlights some key findings and a bit of horizon scanning about what is within the near future in terms of some of the performance issues that we might be facing. So if I were to briefly summarise the key messages into 4 areas where I think we've made significant progress and 4 areas where I think there is real challenge. So those 4 areas of significant progress, as many board members will know, South West London does very well around access to elective care for outpatients, diagnostics and inpatient elective procedures in comparison with many other parts of the country. But that's not to say there isn't further to go given the massive impact of the pandemic on people waiting for access to care. So there continues to be good and strong progress at returning to business as usual activity levels that we saw prior to the pandemic, and indeed stretching above and beyond those and working collaboratively across the system to deliver in that area. So that would be the first area of ongoing success, though more to do. The second area would be cancer performance, where we are as a system meeting the new performance standards around the faster diagnosis standards, amongst only a few areas in the country to do that. Picking a different topic, dementia diagnosis. It's an area that we've been working on across the system for some time, and really important to patients and their families around earlier diagnosis of patients, and we're now significantly ahead of the national objectives in that area. And also learning disability health checks would be my other area where we've now achieved, or very close to achieving, the national expectations around that. So there's more to do in all four of those areas, but there are four areas of very obvious success on which we would want to build as an ICB. I think the four areas of challenge I'd want to call out, and when surprised to people who've seen any of the news headlines over recent months, is the ongoing and immense and very significant pressures on urgent and emergency care across the system, across all channels, be that primary care, be that integrated urgent care, including services like 111, be that ambulance services, hospital services, or services around discharging people into the community. And that's a very real and ongoing pressure. We expect more thoughts and reflections nationally over the coming months, but we also realise we need to push on this now through the summer months to make further progress into the autumn. So a week today we're holding a session with chief executives and clinical leaders across the system to think about what more we can do to reset our urgent emergency care system as we prepare for the winter period and the challenges that will be ahead for us. So that would be the first area of challenge. On planned care, whilst we're, as I said earlier, in a good place in comparison with many parts of the country, we continue to see an overall growth in the number of people on our waiting list. And there's a very strong correlation with people being on the waiting list and then needing access to emergency care at an earlier stage. So that remains an ongoing area of priority and focus for us. I would also want to reflect, whilst many of our cancer pathways are strong, our breast pathway needs more work. That's partly driven by the pressures of demand impacted by the pandemic, but it is a real issue, and we need to build some more capacity into the system to deliver for patients in a timely way. And the fourth area I want to call out is the challenges we face around mental health, which Vanessa, I'm sure, could articulate much more clearly than me, but the pressures around the acute hospital beds, both for adults and for children, and also called out in this report the pressures around accessing psychological therapy services and some of the challenges in those areas. So I've tried to give a balanced report, Chair, of four areas of strengths and four areas of ongoing challenge, but that would be my brief summary of where we are at this point in time.
That's very helpful. Did you want to add anything to update us, Jacqueline?
As Jonathan said, we've been working, and I've just linked what Mark said earlier about the clinical networks. We've got 16 of them in South West London that are jointly led by a GP and a consultant from one of our four acute providers. And that has had a massive impact in terms of how we are managing elective across South West London. What that has meant that what is called high volume, low complexity patients, because we move most of the long waiters, which tend to be at St George's, into mainly Croydon and Kingston, it means that we're now left with a bulk of high complexity, low volume patients on the waiting list, which is, I suspect, are the ones that we are seeing in our emergency care departments, and that is a national, or becoming a national issue, and I'm working with the regional team on how we might address that across London, because it mainly affects bigger organisations. One of the big focuses that we also have is on outpatients. It's probably the area across many organisations that has been the area that's been least ever paid attention to. So how do we really transform outpatient services that is connected into primary care as well? So one of the big focuses that we have is on advice and refer, to make sure that the patient with a secondary care clinician and a primary care clinician gets to the right place first time, rather than either always being in hospital or always remaining in primary care, that we get them access to the right place. And we have a real focus on needing to reduce the national standard of getting to 75% of follow-ups from 2019, which is quite a big ask, but one that we are continue to work on. We're seeing some progress in that area. So I think a real sector work to get us where we are, and even more sector work and integration and collaboration to move us forward yet again. I think that's all I was going to say, Millie, unless you want to ask me anything specific.
No, there might be. Thank you very much for that. I have some people who with their hands up. Dick first, and then James.
Thank you. Just two quick things. One, in the introduction, talk about national data and locally chosen metrics. And I just want to understand a bit more. Are those locally chosen metrics different sets of goals? In which case, could you say a bit about which they are? Or are they subcomponents of generic ones that we see here? And then secondly, just on the integrated care, the care home residents with Coordinate My Care plan, just be helpful to get a bit more sense of those scores between 35 and 60%. Are we expecting them to move up significantly? Is there a story behind it you could say a bit more about?
Thank you. And James.
I suppose for me there's just something about making the links between different pages in this performance report to sort of tell the story really. I mean, when we look at the urgent and emergency care page, we see some of the real challenges in terms of the experience that people have accessing urgent emergency care. I think that the counterpart that kind of paints the full picture around that is then to also understand the pressures on the mental health system and how some of those then, as well as being incredibly difficult for mental health providers, also impact on other parts of the system. And then looking at integrated care, to look at the super-stranded metric, where we've gone from 8,000 super-stranded days to 14,000 super-stranded days in the course of a year. And of course, that is then the pressure that backs up into the ED and is often then the driver of the really poor experience in the ED. So I think there's a real importance with this about finding some of those threads actually within this, and understanding that there are interrelationships between some of these metrics, and actually just taking an acute perspective for a minute, actually there's a number of contributors that sort of add up to that, to those real challenges in urgent care, and some of them are not actually within the urgent care system themselves, but are a function of some of the pressures that we see across the wider system.
Thank you. Mark?
I think it's just to recognise that this is a South West London report, and actually the need for us to, at a local level, also really dig into the data, because underneath South West London figures, there may be pockets that we need to act upon. So it's just to recognise there's a need to do that at a local or a sector level as well.
Yeah, thank you very much. Okay, Jonathan, some questions and some comments from you, please, if you would.
Okay, thank you very much, Chair. Just to Mark's last point, I think what we're trying to do is think across, I said there are obviously hundreds of metrics we could look at, and as Mark is aware, work with place to be clear about where responsibility sits for individual metrics and individual indicators going forward, and that also applies to our provider collaboratives and trusts. So we're working that through at the moment, and we will obviously be providing information at a level of place as well. Couldn't agree more with James's point about the breadth of the challenge. It's a really good number to pick out, the growth in those people who've been in hospital longest, and just how that's effectively doubled over the life of the pandemic, and what that then means about flow through hospitals and some of the impacts. So I think, see a lot of nods around the table from people who are close to this, just how pivotal that is, and that's going to require, through that reset conversation, some thoughts next week about what more we could do around the discharge element of the pathway. And to Dick's 2 points, so there's a range of indicators here. So some are very much national. So for example, all the elective indicators, all the cancer indicators are national. But some are things that we felt through the course of the pandemic that we also wanted to continue to monitor and to continue to focus on. And I'm happy, if you're helpful outside of here, just to draw attention to the distinction between what is in each of those camp. But in that second camp would be the other question you're asking about, coordinate my care and the percentage of care home residents with a coordinate my care plan. The contract with the existing provider for that service ended in March, and it's moving over to a new provider as of now. So there may be a few bumps in the road around data through that period. But would you expect a higher proportion than do to have access to for a very vulnerable population in care homes? Would you expect them to have access to a plan that coordinates what the NHS delivers effectively? I think you absolutely would, and that's why we chose that as a really key metric when thinking about what we pulled together for this report. And clearly working together with some of the committees that support this board, we'll be thinking about how we iterate and develop this report going forward, so it gives people a full breadth of information, but also a bit of precision and focus, because we've all sat in boards where you're sort of drowned in very significant amounts of paper, and I'm trying to find some balance with that, so happy to talk about that too outside if helpful.
Sarah?
Just on the coordinate my care and the differential between the boroughs and you know why some are higher than the other is that it is quite a complex geography around this, because some of these, so coordinate my care has been in some boroughs longer than others. A lot of this is about confidence of clinicians to be able to use the system, how we actually, because we have to work with all of the care homes and LAS and all the GP practices. But with the transfer to the new provider, we're going to provide a lot more training and support out into the community. So we would hope that those figures would go up in all boroughs, but where there are lower, and I know that Annette's in Kingston, so she's they've got a low numbers in there. They would be looking to increase that, I think, over time.
Okay.
Thank you. And just to say that I think the new tool, the new care planning tool, is going to be a lot easier, more easily accessible. It's going to be much easier to use. You won't have people forgetting passwords all the time because passwords won't be required. It'll be immediately accessible from the patient record, and I'm hoping that that will make a big difference to the uptake and the use of the tool.
Well, thank you very much. That's the performance report, the quality report, and the finance report. The two are to come yet. But let me just remind ourselves that this is a very important part of the board. We are required to exercise oversight and challenge, and that's, I think that's how we will develop working together. So it's the first thing. The other thing I would like to remind the board that we're setting up subcommittees where we will have more time to go into more detail and look at more analytical facts and mitigation. So this is an early version, and in future the subcommittees will help the full board to report on each of those activities. The last thing that I kind of wanted to say is that what I think we should challenge ourselves on is to develop a set of performance reports which tell one version of the truth. And I imagine it to be a kind of a Russian doll type thing. So you can go into the detail at the local level if you want to, but that then aggregates up to a system level, or to a APC, provider collaborative level, or to whatever level is appropriate. I know that's asking a lot, but unless we do that, we're going to faff around, to use a technical term. So the challenge on us is to develop those kind of tools so that the board and the subcommittees and yourselves as individuals can properly exercise the duty of oversight. So thank you very much for getting us started on that, Jonathan. All right, let me move us on to the quality report. David Royal.
Thank you, Millie. So the quality report we've divided into two parts. The first part just gives you a taster of some of the metrics that we're going to be measuring in the new ICS. And the second part actually showed you what we've done in preparation to getting there and the governance that is going to be around quality management across the piece. So we've just given you a flavor of some of the metrics. We have about 66 quality metrics that we need to measure statutorily that is being given to us by the National Quality Board. And we've also sort of like picked some local metrics that we're going to measure by ourselves as well, which will then reflect the whole system, which will extend to care homes and looking at also mental health, looking at local authority in terms of social care and how we relate that together to really reflect the whole quality across the system. And you can see we've looked at, there are a few areas, metrics that we've represented here, some ranging from never events across the piece, and you can see in terms of never events what we've, and that will actually relate more to secondary care. But what I will assure you, or what we're going to be doing in the future is to make sure that as we reflect these metrics, we are also benchmarking ourselves against similar ICS across the sector. And I would like to say to you, you might look at the never event and think, oh, look, they've got about 5 never events. But actually, when we benchmark ourselves against similar ICS, actually we are doing well in Southwest London. And also, we've also represented some of our serious incidents, which I think comes in terms of safety. And I'm sure you all want to be assured here in terms of how we are keeping our patients safe across the piece. And we've highlighted that there. Again, what we want to be doing with this is to actually then do a deep dive where we have like sustained high numbers. Again, benchmarking ourselves against national and local data to make sure that we are not an outlier. I think the piece that I want to draw your attention to is infection and prevention control. I have to say that because very much we are in endemic, not hopefully we are out of pandemic. Is to say with IPC and COVID, we've done really well in Southwest London and how we've done our vaccination. But you can see there are other areas that we are really still struggling with. And in terms of things like Klebsiella infection and also Pseudomonas infection. So again, when we looked at that, it's a similar problem we've got across London. It's not just peculiar to Southwest London. However, we have an IPC group across the system that are really looking at this. And I have to really touch on patient experience because there's no way we're going to talk about quality and not talk about patient experience. Again, we are looking at complaints that are coming in, and significant of our complaints actually triple or double. I'm sure Steve is somewhere here in terms of last year, and mainly is about COVID. Hopefully, they are all coming down now, but areas that we are still having a high level of complaints around continuous health care. And continuous health care is an area that we are focusing on. And one other area that we are also, that is of high significance in terms of quality, is in terms of the review of children that are sort of like look after children. They're supposed to have their initial review and sort of like follow-up review. In that instance, we are not doing too well in that, in terms of compliance. But again, this is a system approach. We have a group of people working on that at both health and local authority point of view, which then links into community pediatrics and how we actually make sure that we have enough workforce to really deal with some of the challenges we are facing in the future. I think that's all I want to say in terms of metrics. And on the other part of it, like I said, it adjusts the way we've actually developed our governance around how we're going to be measuring quality across the whole system. And I'm going to pause at that point.
Thank you very much indeed. Okay, James?
Gloria will know the point that I'm going to draw attention to, which is the last point that she actually made around looked after children. But I think the looked after children IHA compliance is actually indicative of, I think, a sort of a wider challenge on the education, health and social care interface really around children, around children's services and around the pressure on universal services for children and also community paediatrics. I think between the various strands of demand on those services, we have seen a really a sort of exponential growth really in demands on those services, and that's both in health and local authority commission services. You know, locally we are certainly struggling, and we're in active conversations about some of the measures we need to take. We're also and thank you to Gloria for leading a conversation across South West London about how we might work differently to tackle some of those challenges. But I do think it's something that as a board we will need to maintain a real focus on, because sometimes the numbers are quite small, but the impacts of the challenges in accessing those services right the way across the system can be very, very great for the children affected. So I do think I'm very glad to see it in this report, because I think it is an area that we will need to come back to.
Thank you. Do you acknowledge? Karen, do you want to say something?
Can I just ask about the Never events, Gloria? So I suppose there's a couple of questions for me. The hospitals are different sizes, aren't they? So the ratio of Never events to hospital size might be significant. I didn't know whether there was something that we needed to do there, but also whether when we track Never events, and it may just not be in the report, which is fine, whether we look at the impact on patients. So, you know, so a kind of an overdose of insulin might have a completely different impact on the patient, both short and long term, obviously, than retaining a foreign object. I just wondered whether the impact was also tracked. Thank you.
So, in terms of ratio of never events, it's something that we can actually look at and bring in the future report according to the hospitals or providers. I want to talk about in terms of impacts. Definitely, whenever we have never event, it's a serious incident, and there's this big investigation around that. And one of the areas we look at is that impacts on patients' care in terms of outcome, and also what is driving that in terms of culture and practice around that, around the incidents, especially what happened in the theatre when we talk about wrong site operation and so on and so forth. But I think one of the areas we really want to look at is where we have the similar never events going on across the piece. How do we bring that together in terms of sharing best practice and learning across the system?
Yes, I did, because I there is a real balance between ensuring in organisations you have psychological safety, that people can report their events, and actually taking a different bit of it. And I think the key bit for us, I think, is our organisations learning. As exactly as she said, not just across, are we having nasogastric tubes is a classic misplacement of nasogastric tubes. Why is it, and you know, in one of my organisations we've had a few, and it's really, they're heart-stopping things when you get told about them, and it's for the staff and for the relatives and the patient. But I think the bit is about the learning culture in organisations that we want to understand and make sure there is a review and people are learning, and how that works and how we can support that. And yes, as organisations, we always look at the impact for the patients. That's the first thing we always ask.
Thank you. And Vanessa.
Thank you. Thanks, Gloria. I just wanted to triangulate the information in the quality report across into the performance report that we received earlier, and obviously the significant increase in demand for mental health services, both for secondary mental health services but also in primary care. And then when you look across and you read across the rates of suicide in South West London and the impact that has on those individuals and those families, I really welcome the fact that Millie, yourself and Sarah, prior to us becoming the ICF, commissioned a piece of work with us, with Mental Health Trust, looking at the South West London mental health strategy. And I think that's going to ask us some really thoughtful areas of focus. But I suppose it was just that statement that actually when you read across, we've got impact now that we need to work on as a community.
And Dick?
I only wanted to re-echo Jacqueline's point that it does strike me that issue of creating the space for learning so that we're actually designing out error is vital, and that is probably something where this board has an important role to play in ensuring that there is such a safe space.
Yeah, thank you. Do you want to make any quick comments on anything you've heard?
Yes, and I just want to say that's one of the key areas we are really looking at. And we've already set up a patient safety, sort of like a forum where all the patient safety leaders across the system sits in, bring some of these issues talk about the learning and share it widely. And we are doing newsletters as well that we're going to be disseminating about. So really the key thing is about how do we really share learning. I think that's the big. And also how do we then put quality improvement projects around the areas that we are struggling with so that we can start seeing that decrease in terms of the prevalence and numbers. I really want to say that. And in terms of mental health is very key. And we've already flagged this at actually London level. That is one of the areas we are worried about. But it's not just about Southwest London. I think we've seen significant increase across London. And I think really, I agree with you, we probably need to really do a piece of work, really looking at how we do that across, not just secondary care in terms of AIE, it's across the whole piece. Thank you.
So I think what we've heard with our first couple of reports in this section is the emerging agenda for the future. One of the things that I wanted to update you on is we're developing a set of board development sessions so that we can all learn more about these issues and start to look in more depth about how do we move forward. And one of the first ones that I think we've agreed offline will be on children's mental health. I think we have all recognized that there is a risk here that Vanessa has just begun to hint on, but we know ourselves very well. And to James' point, even this morning, James, they cared for children I forget what they call it, kinship. The kinship group are making a report. So we really must work very hard to develop our own understanding. So we're going to do that as an early development session. The other thing I wanted to mention to you is today we haven't got any patients here specifically, and one of the things we want to develop is how do we hear from patients. There are systems in place in trusts where you regularly hear from patients, but also as a system, I think we need to remind ourselves what patients are saying, and in order to create the right kind of culture, and of course the balance between, enabling people to be honest and report things, but also recognizing when things go wrong. The last point I wanted to make in that vein is we also will be looking at complaints. We haven't developed the methodology yet of what is appropriate for the system to look at, but we will be developing those reports and looking at complaints, and no doubt the quality subcommittee will be very engaged in that. So thank you very much for that. Right, now we move on to money. Sorry, was that something? No. Now we move on to money, and we've got Sarah actually telling us about money.
Yes,
Sarah.
so I do have to explain why the Chief Executive is presenting the money. It's because currently we don't have a Director of Finance. That is because our Director of Finance finished yesterday, who was the Director of Finance, James Murray, and I would like to welcome Helen Jameson, who is going to be our new Director of Finance, I can't remember, is it Chief Finance Officer, and she starts on the 18th of this month. So welcome. I didn't know if you wanted to just say hello, Helen, before I launch.
Yeah, I just wanted to say that I'm really excited to come back to South West London. I started my London career at Kingston, and so I feel like I'm coming home, so I'm really looking forward to working with all of you.
Thank you. So hence the Chief Executive is now presenting the finance report, so please be nice to me. I have actually got some help in the audience from one of my finance colleagues, Joe. So if anyone asks anything difficult, Joe will run to the table to answer the questions. But this is a slightly different finance report because normally in the board we would have had a finance committee who would have gone through all of the detail and would be bringing a kind of confirmed position to the board that people felt comfortable with. We're not in that place. Firstly, this has been through, the detail around this finance report has been through a finance committee. It was a finance committee of the CCG, and if you remember, the position is that of the CCG because it was the statutory body until the 1st of July. I think it's worth saying that. Secondly, the finances within an ICS are very complex. And I thought rather than going through a detailed finance report, which actually at the beginning of the financial year is never exact because, you know, you're just building what the position is throughout the year, is to actually just give a bit of an overview of the way in which we work, and then to give a position, but also then the opportunity to go away and have the detail in the next finance committee, which I know Dick will be chairing. So that's the way I thought I would approach it, rather than going through as a finance, just because I can't do it. Firstly, just remembering that our finances are quite complex in that we as a board, the ICB board, do have a budget. That is the budget that is given to us by NHS England to deliver services within our local area. That budget pays for some of the services that are provided through the hospitals, through general practice, in other areas, but there are some budgets that don't sit with us. So there is money that is spent in South West London that does not sit with us. So we have patients that come from outside South West London and receive services within South West London. And we also have some services that are have monies coming directly through from NHS England or from other areas. So we have two budgets to look at, really. So we have the one that we hold, and then we have the one that is how much money is spent across South West London. So the budget that Jacqueline has for St George's is much bigger than the money we give her. She has money that comes in from lots of different places. But our requirement as a system is to balance across the system. So the system budget has to balance. So the ICB part of it actually could be under or overspent, and Jacqueline could be under or overspent to balance that out, just so we're clear. So it's quite complicated. But I do think it's worth just setting that out to start with. Secondly, I thought I'd take you to the part that talks about how we've done the plan rather than anything else, which I think is on page 8 of the pack. And just to say that we have actually, as a system, submitted to the regulators a balanced plan. And all organisations within South West London are planning a break-even. Now, the 3 million difference between the Marsden and us as the ICB is a technical issue, but in order to put a balanced plan in, we've got 3 million plus here and 3 million minus there, in case anybody was wondering about that. But within that plan that we have put in that is balanced, it involves having a 7% system cost saving. That is a large cost saving when you think that normally organisations in the NHS would do between 3 and 4% saving, so 7% is quite a large saving. This is a high savings plan, but it's been, you know, we have had a balanced plan in South West London in the past, but we have got now the impacts of COVID, we've had rising inflation, the cost of living is going up, as you know, and there is still a continued impact of COVID and urgent emergency care that we have talked about, and those are the things, and workforce as well, those are the things that are impacting on us having to deliver that plan. So I don't want to underestimate the challenge that is associated with that, but what I would also say is we do have some non-recurrent funding in the system, but it's important that we actually reduce what we are spending within the system so that when we go through into next year, even if we use some of that non-recurrent funding, we can still be balanced going into next year. It's very difficult this early in the year to actually say, how are we doing? There are two reasons for that. One is because we are just at the start of the year, the numbers are just coming in, and I wasn't going to go through that in detail. But what I think it's important to say that a lot of our plans are actually going to deliver later on in the year. So we may not be delivering everything in the first few months, but we are expecting that to increase. So it will be important for us as a board to monitor that and to understand that we may not hit all of these targets, because this is a very, very challenging plan. And then we will need to look together across the system, is there any mitigation that we can put in place for that? So I wasn't going to actually say much more than that. I'm going to bring Jo in if there is anything very technical, but I think really if there's any very technical and detailed questions, those will be really for the Finance Committee, and then when we come back to the next meeting, we can have a more robust conversation about where we are now in this round. Is that okay?
Yeah, that's perfect. Thank you very much indeed. Questions for Sarah? Comments? Did you have one?
That's all right. So I think it is an ambitious plan, and we all know that, and 7% SIP is not something we've ever delivered before. But I suppose it's just about us really, about whether we can do a bit more work on the risks of that as we go forward. I know we've got some risks in there, and I've been doing a bit of work with the team about what that looked like, both in terms of what could happen if we hit that target and what could happen if we don't. So I think those are the two. There's lots of other bits that sit within that, I know, but I think that they're both of quite high risk places to be.
So yes, thank you. And I think it's really important. There is some risks in here. There's a lot of risks around this. A lot of our spend is in the hospitals, so I think that's why there's a little bit of focus on the hospitals. But we have put in, I think this is important as well, some process around governance and oversight of this. And what I would say is the strength of South West London in this is that we are all working together on this. We're not trying to blame each other for the financial position. We are trying to work together as a system to get the most productive and efficient number out of this at the end of the year. So I welcome the kind of focus on the risks. Can I just mention one more thing really, which I did forget to mention, but I think it's important. We have protected some money for South West London, and that is two in particular that I want to point out. One is the Inequalities Fund that was mentioned by Gloria, really important for the board, I think, to recognise that. And the second one is an innovations pot that we think is really important to allow us to do some of the work that might actually help us to transform some of these things to be both more efficient but better for patients. That's it, sorry, Manny.
Thank you very much, and thank you for those questions. I just want to add a couple of comments. First of all, starting where Sarah ended. We have to believe in some of the programs, and one of them was the Equalities Fund, so we got the money and we didn't need to fritter it away, so it is protected. And we didn't have this board to ask, but in the previous manifestation of the governance system, we agreed that needed to be protected. Equally, we very much believe in innovation, in the Innovation Fund. We don't know quite how we're going to use it yet, but you know, everything you've heard today, you know we have to make some changes. And the purpose of that Innovation Fund is fundamentally to enable some seed money to make that change. Because if we keep doing things as we've done before and incrementally add or subtract, we are not going to be able to make the change. It's not a huge amount of money, but it should be enough for us to start making those changes, and we will keep reporting back to the board on that. I think, as the chairman of the ICB, I really must emphasize what Sarah said and what Jacqueline has said. It's a very challenging plan. And it isn't just the risks, but also the mitigations that we need to discuss. And also it's a backloaded ban. So one of the things that we should start to worry about is not just this year, but how we end the year. Because how we end the year is going to be the start of the next year. And the next year worries me greatly, because I don't think this is a one-year phenomenon. None of you think it's a one-year phenomenon. So it's really important that we bear that in mind, and as we look through the mitigations, we actually start to look at the continuity of it. I know we, in the NHS, we primarily work on one-year budgets, but you know there is whispers that might change, but at the moment we have what we have. So those are the contextual issues that we should bear in mind. Okay, so we've come to the end of the formal part of the board, but I just wanted to say a couple of things before I move into questions from our colleagues and other people who are sat around this room. I mentioned early on the 4 things that we as a system are required to do by law, and I would just like to emphasize that we have actually started to talk about those. So we've talked about population health and that the work that is in progress and the more work that's to be done. We've talked about inequalities and again the work that we've done and work that we want to do. And we've just talked about money, because remember we are obliged to look at productivity, which is different from value for money. And I think it's a really important distinction as we go through this year in looking at those mitigations as well as those risks. Is what is the productivity that we can bring to bear that we can build into the sustainability picture. We didn't today talk about our position in the community, but at a future date we will do so. So I think we wanted as a board to start off as we mean to go on. So I'm very pleased that we have actually addressed significantly 3 of those issues, and we will address the 4th one. So on that note, I'd like to thank board members for their contribution, and I want to now move on to questions. And the first set of questions is open to our partners and colleagues from the voluntary sector and from Health Watch. I would encourage you to ask a question, because then you'll get a response rather than make a statement, because that's just make it easy for us to respond. So if you will bear that in mind, that I would be very grateful. Liz has already got her hand up, so go for it, Liz.
Adjusting the microphone for a short person. Yes, I hope that my first questions I can do justice to, because it is an item that was a little while ago, and these are questions, some of them I'm afraid are observations, not questions, for Mark in relation to the fuller stock take. And just picking up on the point that Dagmar was making about the importance of involving elected members in the conversations about the reforms to primary care, that's something also that Health Watchers would be very interested in being involved in. And really part of quite a large conversation about the changing skill mix in primary care and what it is that users of primary care will see in their encounters. So one of those will be around the new members of the team, around the greater involvement, for example, of pharmacies and so on, so that, you know, we do have a fully informed conversation. Because I think that the more that all of us as members of the public know what to expect in the new world of primary care, I think that you know, the easier it will be to work with that. There is also a large literature in sociology on how people engage with primary care, and particularly with GPs, and I don't very often see a use of literature reviews, not huge tomes, but, you know, short ones, because you know, there's at least 30 years of literature in relation to this, and that might help get a more nuanced view as well. As well as the issue of skill mix, which I think it is important for the general public to understand, I wanted to pick up the issue of digital and the shift to digital, and having more nuanced conversations with the users of primary care about how digital is being used now, and also to pick up on the Health Watch England report that came out about 18 months ago, where I think it was about 15% of the population did not feel comfortable using digital, to make sure that that is adequately planned for. I think there was another report about a week ago, it might have been Age Concern, making a similar point, and they were also pressing for there to be some kind of regulation of how websites are put together, because they were picking up that quite a lot of particularly older people, of whom I count myself, do have difficulty using websites, and you know, that attention to that actually might make the move to digital easier.
Liz, could I kind of move you along, if you don't mind?
Okay.
Because I want to give other people opportunity to ask questions.
Sure, yeah, that's one of the problems, trying to collect all my points, I'm afraid, Millie. I also wanted to just briefly pick up, in relation to skill mix, the importance of proximity. Because when people are in new roles, they're developing the role as they go, they're learning from each other, and therefore it's important that they actually have physical proximity.
Okay, well, Liz has asked a number of questions. What I would encourage you to do in response is to respond to what you can now, but this is not the only encounter we will have, and we will, of course, record your questions, Liz, and we will follow up outside the meeting as much as we can. Thank you very much.
Could I just clarify, will I be able to ask a brief question to Gloria and also a brief question to Jonathan?
If you can keep it very brief.
Yes, they are briefer.
I think that's appropriate, isn't it? So let me just get Mark on the line, and then Mark to answer first.
Okay, so thank you, Chair. And Liz, just in terms of the fuller review report came out probably about 4 or 5 weeks ago, so we're at very early stages. I think part of the conversation, absolutely, I would really value a conversation with you about how we involve the patient in the evaluation of new members of staff and how we take forward the fuller review recommendations. I think in terms of proximity, I agree, we need to make sure that we are that the staff are where we need them to be and actually addressing the need locally. And then the difficulty using websites. I think I made the comment, we really need to ensure that we're doing things in different channels. Digital doesn't suit everyone, we recognise that, and so therefore access is about doing it on multiple channels, not just digitally.
Thank you very much. And I think on that last point, Mark already said that earlier on, and we recognise that. So thank you very much, Liz, and I'll encourage you to continue the discussion. I'm sure you will. 2 very brief questions for the other 2.
Yes, I'll take both together if that would be quicker. My question for Gloria is in relation to the core 20+5 work, which has, I think, been around now for about 18 months, slightly longer. That since then we now have a cost of living crisis, and what effect that might have on the core 20+5 work that's being undertaken. And my final question is to Jonathan, and that's about the work on dementia diagnosis. And it was just picking up a report that was in the press last week that the South Asian population is being very badly underserved at the moment by dementia services, and that might be worth looking at locally. Thanks.
Gloria.
Thank you, Liz. Can you please repeat yourself in terms of the crisis element? Sorry. Liz?
Sorry?
Can you repeat the question in terms of the crisis element?
Yes, it was that since the core 20+5 work was initiated about 18 months ago, we are now moving into a cost of living crisis, and I was wondering what effects that might have on the core 20+5 work that's being undertaken. Thanks.
Thank you, Liz. And I would say that is an area that we are particularly worried about because, again, if you look at those 20% deprived population, definitely the crisis that we are facing now will have an impact. One of the things I know at borough level, there's a lot of projects going on in terms of assessing that impact, especially around children and people that are living in poverty. So I think what we might do maybe in the future, or probably if I can work with you out of here, Liz, is to probably look at what locally we've done so far. But I know there are pieces of work going on in terms of looking at that across the system.
Thank you, Gloria. And Jonathan?
Yeah, thanks, Liz, for the question. Just to give a bit of context, if we're looking back, say, 5 years ago, the proportion of patients diagnosed against the indicator I talked about would probably be in the sort of 30% range. So we're getting it to 70% for the system is a real achievement. But it links to Dagmar's point earlier. That still means 3 out of 10 are not being diagnosed. So what I would find really helpful, and it relates to a whole programme of work that we need to take place across all our work streams, including things like waiting lists too, and one of the core priorities of the board around inequalities, we need to get underneath the detail here. So it'd be helpful if you could share the article from the South Asian communities, and we'll have a look at that. And very happy to talk outside this once I've had an opportunity to absorb that and see what information we do have and what information we don't have. Is that okay?
Yeah, thank you very much indeed. Now, Bruno, do you want to ask a question?
No, it's not Bruno.
No, sorry. Sorry, will you introduce yourself?
Yeah, thanks, Millie. Simon Shimmons, I'm the CEO of Merton Connected, so welcome to sunny Merton today. But I'm here on behalf of an alliance that's being developed for the 6 VCS organisations. So we all represent the voluntary community faith sector in the individual boroughs, but I'll use the term VCS as a collective for that. I've got 5 very brief questions, but they probably won't need answers today.
Could you sort of merge them up? So that
I've already done that, but just to pick up on some points. On Mark's point around primary care, there were 2 points there. Sarah, you talked about the front line of NHS being primary care. I think possibly ICS can move the narrative over time that actually the voluntary community sector is the front line of the NHS, because we talk about it, but we need to engage it more fully. So that's an ask. I think picking up on Annette's point on that and what Mark mentioned around community settings, the voluntary sector is under incredible pressure at the moment financially. The cost of living crisis doesn't just affect residents, it affects organisations. I've heard of people already who are turning the heating off in face-to-face sessions for residents who've left a home where they've turned the heating off. So I think if we can look at utilising co-location with the community and voluntary sector, we can certainly meet that 4th objective of the ICB, because that helps social and economic development by maintaining a healthy voluntary sector. 3rd point, we had things brought to life by SI today, and I just ask that on all boards influenced by this board into ICP, into the borough committee, that the structures of meetings do feature experts, subject matter experts, many of which sit in some very small voluntary sector organisations on subject. When SI brings it to life, there's a lot of people in a lot of areas, as we know, dementia, mental health, that is doing preventative work before they engage with the NHS, and I think it will be important to hear their real-life experiences of it. 2 final questions very quickly, and this is on very much on behalf of the South West London Alliance. If we are going to engage the voluntary community faith sector very successfully going forward with ICS, there will need to be some change in commissioning to allow that to happen, because the very small organisations have not got any infrastructure in the way that provider collaboratives have to directly receive NHS funding. And I know some of that will be buffered through place committees, but the combination of commissioning that will allow organisations to come in, and also longer term funding, as we know in every sector, can magnify the impact of what gets delivered. So that's, in a way, Millie, these are asks. They don't necessarily need responses today in the interest of time, but thank you.
Well, thank you very much. Could you just answer if you can, or take it away and deal with it, please?
We can absolutely take it away. I think actually what you made very valid comments, particularly about the voluntary sector being frontline. I also think the co-location of service delivery is really important, and I think we've got examples of that. I'm thinking of HIP in Wandsworth, actually, where we're delivering services with community organisations for the community. And absolutely about the voluntary sector. I know that we're having conversations with Charlotte and yourself and the Alliance around what the funding mechanisms might be in the future.
Okay, I'll encourage you to have conversations outside of the board, and I said that right at the beginning because it's about developing the relationship stronger, but thank you very much for your questions. Now, if you read your website instructions, you know that we're going to give priority to the questions that have already been sent in by email, so I have a few here. The first was asked by Mr. Merton, who is from the Mitcham Cricket Green Community and Heritage Group Secretary, and it was about the Wilson and the Wellbeing Hub. I'm told I must look at you, Mark.
Yes, back to me. Just to say that to recognise and acknowledge that actually an East Merton Health and Wellbeing Hub has probably been in conversation for about 20 years. At the end of last year, we were able to identify funding, which is a combination of property services funding and CCG funding at that time. We then had to go through a process, and that process was to identify the preferred site for the NHS. We've gone through that process, and in April we took it to the programme board, and the Wilson was the preferred site. Now, April was just before elections, and actually there was a pause. But actually, since then, there are two conversations we still need to have. One with the Mental Health Trust around the size and the scope of the services that are going in there. That will allow us to move to the next stage of the business case. And then secondly, with our local authority colleagues at the Health and Wellbeing Board, recently they asked us to have the conversation just to make sure there wasn't other sites that we hadn't considered. So those two conversations are taking place. We anticipate they'll be finished relatively soon. Just to say that we are really committed to the Wilson. It is the NHS preferred site, and that we hope to then have stakeholder engagement following the conclusion of those conversations. Just to say we will engage around the Health and Wellbeing Hub, and then the residential developments that will happen after that, and just to say that the hub is dependent on the sale of land, that will be for the developer to take forward within the council policies.
Thank you very much, Mark. I hope Mr. Merton is happy with that answer. We had a question from somebody who manages a deaf care home about British Sign Language. I'm told, Charlotte, you're going to help us with that?
Yes, so going forward, Millie, we're going to sign our kind of video recording of this meeting and look into how we kind of do that more extensively so all our meetings are transparent for members of the public and all different types of communities.
Thank you very much. I've got a written question from Mr. Rob around GP representation and place committees and ICB. I'm told I would look at Nicola for that.
Thank you, Millie. Yes. So the national deadline for delegation of the primary care functions other than general practice is April 2023. And in London, because of the scale of the changes to establish ICBs and all the other pressures in the system, it was decided not to progress immediately, but to aim for that April 2023 deadline. So in reality, only a small number of ICBs anywhere in the country are looking to take on pharmacy commissioning, which I think is what this question is about during this year. The national guidance regarding the establishment of these boards has also been that in the first instance, the primary medical services partner member should be a GP. But as with all members of the Intri board, the role of that member is to bring the knowledge and experience of the sector to the board, not represent individual areas. And perhaps as an additional point here is that there's always a balance to be achieved when you're constructing a decision-making body between getting a broad input versus ensuring the board is small enough to be efficient and effective. However, I really recognise the concern that this question has raised, and in my role I'm required to ensure that the ICB is well advised about all things primary care, which doesn't cover other services in the community, not just general practice. And whilst I may not have the detailed understanding of what goes on in pharmacy, like someone working in that service would, as a professional working in the system for many years, I'll endeavour to ensure that the board is advised. And where I lack the expertise, I'll ensure that, if I don't personally possess the knowledge, that the board will understand that and will get the information that we need.
Thank you very much, Nicola, for that reassuring and professional answer. I have a question also from Chris Edge. I don't know if it's Mr. Edge or Miss Edge. About the makeup of this board. He's concerned to ensure that we have a full range of skills, including commercial skills, and I'll take it upon myself to answer that because I've been intimately involved in selecting this board. I would like to assure Chris Edge that we do. A number of us may look as if we only are public sector people, but actually if you look at our board biographies, we have experience across the piece and we've got a couple more other vacancies to fill. So very aware that a board has to be comprehensively skilled, and that's what we'll try to do. And also I can give an assurance that where we don't have the skills, we will bring those skills in to advise and inform the board, and that will be part of our development sessions so that we don't spend all our time, just agreeing with each other. So thank you very much for raising that question, and I'll give you my assurance. On that note, I've got a few minutes left for any questions from the public. So please ask very brief questions. Mr. Rob, I'm not going to come to you now because you've just asked a question. So, sorry? No, let me ask the question of the other. Yes, please, give your name and ask the question. Thank you very much.
Good afternoon, everyone. My name is Abdurrahman Hirsi from Elais Network, a grassroots organization based in Southwest London. We all know and acknowledge that COVID-19 exacerbated the existing health inequalities with so many communities. We also know that grassroots organization became the first point of contact and main point of support for those communities whose health care experiences got worse in COVID-19. My question is, what is your strategy and action plan into building the capacity of those community organizations so they continue delivering and co-designing services that are locally tailored? Thank you.
Well, I think that's a very good question, actually. So anybody like to just comment on the thoughts that we've had, Charlotte?
Yes, I think we totally agree that a lot of the voluntary sector were our front line, as we've been talking about in the meeting. And as Simon was saying in his questions, we are coming together with the voluntary sector to create a voluntary sector alliance for South West London, so we can work together more collectively, but also at place levels. So at our place committee, our voluntary sector leads will be equal partners around the table, so we can do better to engage with the voluntary sector, not just around reaching into communities and hearing that kind of rich, diverse community voice, but also in co-producing and designing our services together. So hopefully, with this kind of new era and this new board and system way of working, we can do a lot better to kind of work jointly with the voluntary sector. But we have got a long way to go.
And thank you very much. Another question from the public? Any other hands? Yes. I'm going to take two more. The lady at the back and the gentleman in the front.
Thank you. Good afternoon. Councillor Anita Sharper, I'm Chair of Kingston Health Overview and South West London, Joint Health Scrutiny. Just hopefully a quick question. I was just interested in listening about the part of the wider strategy, the long-term strategy that you have. What I'm interested in is when you talk about scale and consistency, sort of highlighting those two terms, because what I'd like to understand a bit better is sort of bearing in mind that, as you say, there might be a need for staggered delivery, particularly looking over the next sort of even year, 18 months, and all the changes that can happen post-pandemic. Do you think, to understand, will there be an emphasis on local authorities looking at their assets and infrastructure? Because I'm hearing that, be interested to know how that's linked in with your wider strategy, long-term strategy, and what you think, how key is that going to be moving forward? Thank you very much.
Okay, well, good question. Sarah.
Well, and also maybe some of our local authority colleagues might want to come back, so Ian might want to come back.
Yes.
But I think absolutely that's the intention, and I think we've got some really good examples where we started to think, and actually the discussion that we just had about the Wilson, that's been done jointly with the local authority in Merton and working to think about what that community hub may well look like, that it's not just about the NHS, but about the health on the high street and the work that we're doing with local authorities on those kinds of things. So I think absolutely yes is the answer to your question. I am absolutely no doubt that we can do a lot more together, and I think being an integrated care system gives us that opportunity, and having our place committees that are actually jointly owned by local authorities, voluntary sector, local people and the NHS is going to be key to our success in those areas.
Ian, did you want to say anything? No.
I can do, but no, I think Sarah covered it.
Thank you very much. Thank you for raising that question. Gentleman in the front. Gentleman in the front, please.
Thank you. Thank you, Millie. Malik Gul, Wandsworth Community Empowerment Network. Can I just start by, first of all, congratulating you on the board. I know a huge amount of work has gone in to set up the ICB to where it is today, and I really enjoyed the kind of rich conversations that we've had. The last NHS Race Observatory report talked about institutional racism and how our healthcare systems are institutionally racist. And I know that we've skirted around some of those issues today, and I will come to my question, Millie.
If you would, please, Mike, that would be helpful.
No, but it's not just a straightforward question, because if you talked about the comprehensiveness of the skills on this board, I mean, this board is not entirely representative of the communities in which we seek to serve, if you just look at the kind of representation of this board. And the issue of structural racism, because certain people, as you know, come to the top, other people don't come to the top. And everything that we've talked about today, on every single indicator, you will know from maternity to early years, to children, to mental health, to diabetes, to looked after children, right across the life course. It's our black communities that are most underserved and are least likely to get the services they want. So my question very much is this board going to develop an anti-racist strategy, and not just develop an anti-racist strategy, but put the resources behind that? Less than 0.1% of the last budget goes directly to BME communities. So black lives must matter, and they must matter as much as white lives matter.
So I'm going to answer that one in the various detail that you've asked. Firstly, about our commitment to equality and diversity is absolutely clear, and we will bring back several papers as we move forward. But in the meantime, I'd like to assure you that we have governance systems in place where we're looking at equality and diversity, where I personally chair the committee for South West London, and Gloria is the executive. So you can be assured, I will assure you personally, that we continue to look at that as a very serious part of our objective. Gloria.
I just want to confirm that we are developing an anti-racist framework. It's in the document here. And because there's no way you're going to talk about health inequalities and not talk about anti-racism and discrimination. And we'll be getting people together across the system to really help us develop that.
And the other question you asked about the representation on this board, I've built this board very carefully. I'll take personal responsibility for it. We want it to be as representative as possible for all the skill sets we require, the people who can come and help us, all the expertise we require, and the independence of thought. So I am very convinced that even though you don't see a sea of black faces in front of you, that we are going to be absolutely focused on equality, and we are going to absolutely focus in bringing the various perspectives that is appropriate to deal with the challenges that we are presented. So thank you very much for the question, and you can bear with us now. Rob is putting his hand up. You have already asked a question.
But you promised I'd be at the end. You said I'd be able to.
All right, this is the end. So your question, please.
Yeah, thank you.
A very quick question. I'm going to close the meeting.
Yeah, okay. Preempting the reply from my question, I had an email from Lord Hunt of King's Heath this morning in the House of Lords. He's the champion for local pharmacists, and he's taking the issue away of no representation for local pharmacists on this committee and the borough primary care committees. And he's going to sort of look at it from the House of Lords. So,
okay, so I don't know that if we can comment on it because we haven't seen the email. He hasn't written to us, but thank you very much for making us aware. Somebody here will take away that and send you a comment. Is that okay? Okay. Well, thank you very much, everybody, for your participation. I'm looking at our colleagues from the community and the members of the public. Thank you very much for taking the time to come here. We very much appreciate that because that makes us feel connected, and please continue to be connected to the ICB board. So thank you for attending. I'll bring the meeting to a close now.